Okay, good morning, everybody. This is the Public Justice Center's Justice for Breakfast, the latest in our series. And today we're going to be talking about Hep C. Ashley Black, who is the lead attorney on Public Justice Center's Health and Benefits Rights Project, will be leading the conversation. She also has with her a number of colleagues that she'll introduce. And like I say, we will be having question and answer after the presentation. You might want to put your screen in a way that Ashley will be sharing her screen in a PowerPoint. So you want to maximize that with a side-by-side view or a presenter view. Otherwise, let me introduce Ashley. She is our health and benefits attorney, and I'll let you take it away, Ashley.
Great, thank you so much, John. Welcome, everyone. We are so excited to have you all with us today and to share the work that advocates have been doing to eradicate hepatitis C in Maryland. So just as very brief background, since a new curative treatment came out for hepatitis C in 2014, state Medicaid programs have sought to control costs by implementing certain criteria that actually limits who can access the cure, including Maryland's own Medicaid program. What we're going to share with you today is what hepatitis C looks like in Maryland, the impact that Maryland Medicaid's treatment criteria has had on patients' access to the cure, the barriers that we've eliminated to get access to the cure for patients, and the barriers that remain to be addressed. I'm joined today by several advocates that we've been collaborating with on this advocacy. But I just want to say before we have them introduce themselves, this is just a handful of the advocates who are working on hepatitis C medication access in Medicaid. Across Maryland, there are, and I won't name specific names, I'll just name categories, but there are legal service providers, policy advocates, patients, researchers, clinicians, and legislators all working to expand access to the cure for Medicaid beneficiaries. So with that said, I want our panelists to introduce themselves, their organization or affiliation, and their connection to hepatitis C, and I'll go last in doing that. So let's start with Catherine Fowler.
Hi, good morning, everyone. My name is Catherine Fowler. I'm one of the co-chairs of the Maryland Hepatitis Coalition and the Director of Nursing at Healthcare for the Homeless. Thank you for having me today.
Okay, and next we will have Kara Bauer.
Hi, my name is Kara Bauer. I am a steering committee member for the Maryland Hepatitis Coalition, and I work for Total Healthcare as their clinical educator, but I'm representing the Maryland Hepatitis Coalition, not Total Healthcare today.
And Joanna Diamond.
Good morning, I'm Joanna Diamond. I am the Director of Public Policy for Healthcare for the Homeless, and I do advocacy alongside Ashley Black to access hepatitis C treatment in Maryland.
And then Dr. Amanda Rosecrans.
Hi, I'm Amanda Rosecrans. I am a clinical chief at the Baltimore City Health Department, and I oversee the hepatitis C treatment program that we have at the health department, including a mobile clinic, and I am passionate about treating Hep C.
Great, and I will go last. Ashley Black, Public Justice Center. I lead our Access to Health and Benefits project. PJC first started working on hepatitis C medication access in Medicaid in 2018. I also have a personal connection to the issue. One of my family members passed away last year from complications related to hepatitis C that they had been fighting for a very, very long time. And even after they got access to the old cure, so this was not the new version that exists now, even after they got access, the damage had already been done to their liver, and they passed away from liver cancer last year. So I think for all of us, this is an issue that touches our lives in different ways. It touches our patients, our clients, our family members, and other loved ones. So as we get started, we're going to go to talk about what hepatitis C looks like in Maryland. Amanda and Kara are going to guide us through that.
Great, so just a broad overview of hepatitis C. So hepatitis C is a virus. Hepatitis A and B are also viruses, and they're all related in that they affect the liver. There are vaccines for hepatitis A and B, but not for hepatitis C. Across the country, there's about 2.4 million people living with hepatitis C and about 40,000 people in Maryland. And it is spread through blood contact with somebody else who has hepatitis C. So the most common pathways for transmission are shared drug use equipment, getting tattoos with needles that are not sterile, and any other kind of way that you can have contact with somebody's blood, which includes mothers transmitting to their unborn babies. There's about 10% chance of that if a pregnant mother has hepatitis C. And also more rarely spread through sexual encounter. So because of the way that it's spread, there's different groups of people are affected differently across the US. So some studies show that people who use drugs have a percentage of 50 to 80% prevalence of hepatitis C. People who are incarcerated, the prevalence is up to about 35%. African Americans are twice as likely to have hepatitis C as white Americans. There's also a large group of people who are in what we call the birth cohort. So people born, the baby boomer population born between 1945 and 1969 have quite a high prevalence of hepatitis C. And this is actually because hepatitis C wasn't discovered until the late 80s. And there was a lot of transmission amongst this baby boomer population before we knew about hepatitis C, before it was screened for in the blood supply. But in recent years, more of the younger population is contracting hepatitis C particularly because of the opioid crisis in our country and increased drug use. So right now, last year, the screening recommendations for hepatitis C expanded to include a recommendation that all adults get screened for hepatitis C at least once in their life. And those who have ongoing risk factors get screened annually or as they have risk. A little bit about the natural history of hepatitis C. Once you contract the virus, about 20% of people actually, their body clears the infection without any treatment. The other 80% of people go on to have a chronic infection with hepatitis C. And that means that the virus stays in the body and affects the liver until it's treated and cured. Amongst those people who have the chronic infection, over years and decades, about 20% of those people are going to develop significant liver damage called cirrhosis. And once someone develops cirrhosis, it can progress to the point of liver failure, but also they're much more likely to develop hepatocellular carcinoma, which is a type of cancer in the liver. Deaths related to hepatitis C are most commonly related to cirrhosis and cancer. So even though it takes many years to amass that amount of liver damage, we want to identify and treat and cure hepatitis C as soon as possible in somebody's infection to prevent any kind of damage to the liver. It is actually responsible for more deaths than including HIV. So it really causes a significant amount of morbidity and mortality in this country, and it's curable. Kara is going to talk some more about what treatment looks like.
Yeah, so currently treatment's very, very easy. It's taking a pill anywhere from 2 months to 3 months. And sometimes there are some other things people take with that to improve the success of the medication if they have some barriers, like they've been treated before and it really did not work, or if there's a level of damage to the liver, and those are less common because we're screening better and better. We're not necessarily seeing other things other than just the pills being used. But back in the day, hepatitis C was actually very hard to treat. And the treatments started initially with this injection called interferon, which basically feels like you're getting the flu. And people would have to give themselves these injections. At first, it was every day, then it changed to once a week. And then on top of this thing that makes you feel like you have the flu, makes you really depressed, they would have to take these pills called ribavirin, which were these very damaging pills, which, you know, could affect your blood cells and just make your body also feel bad on top of this thing that made you feel like you had the flu. And what we didn't even completely understand how the ribavirin worked. So it was kind of like throwing darts at a bullseye and hoping that we really hit it. And it was about a 50% cure rate with those two therapies. And you can imagine that when you don't have a really, we're talking about COVID vaccines right now, and like we are talking about, you know, 94% success with these vaccines, and when we get something where it's lower in like the high 70s, low 80s, we're like, oh, that's not good enough. Just imagine a therapy like this, the interferon and the ribavirin, where you're getting around 50%. That's really not great. And so a lot of providers, depending, because it was so hard to treat, because on top of that, you would have to be on these regimens for about a year. And some people would have to be stopped on them because either their virus wasn't going down. So the whole point of these medications are to make your virus go down. If it wasn't working to make your virus go down, or if you're getting such severe side effects, like your white blood cells could be affected by these treatments. And if they were to drop too low, and we couldn't, sometimes we'd give people like other medications to boost up their immune system. But if that wasn't working, we'd have to stop them on the medications. And because you had to track with labs, because you had to monitor to make sure that it was working and making sure that the side effects were not too damaging, some providers opted to not treat certain patients until their liver got really bad. So when you have a liver, your liver is a really interesting organ. It filters everything in your body, and it grows really nicely. If you take part of your liver away from your body, it can regrow. It's a really resilient organ. But the problem is when you have something constantly attacking it, it can't heal as well. So then what happens is it starts to develop these fatty pockets and these like harder areas. And we call this fibrosis. It's a hardening of your liver. And then the problem is when you have something that used to be really flexible and could filter everything, it helps you in so many different ways. It releases sugar for your body when you're sleeping. It filters out all the bad things in your body, and it can't do that job. Over time, you start to have problems just in general. And then when tumors form, that what Amanda was talking about, the carcinomas, that's cancer. So then when these tumors form, then you've got this thing that's so vital to your body being so damaged. And the cool thing about the new therapies is that they're really effective in helping your liver early on with a higher success rate, you know, in the 90s. And so when we compare the old regimens that at first, you know, you're getting success rates in the 50s, then we added another medication that had more side effects. It was kind of complicated. You have to eat food when you take it for one, and then the other one could cause skin symptoms. And those only got it up to the 70s. Then with these new one pill, once a day regimens, we got people up to the 90s. They weren't having the side effects from the medication. You don't feel like you're having the flu for a year. You don't even have to do it for a year, and you don't have to have labs drawn all the time. It was a game changer. Suddenly treatment was easy, and you didn't have to be so afraid about what was going to happen to your patient. Let me tell you, when I had a homeless patient who also their white blood cells were dropping, that was terrifying because their immune system just couldn't keep up. So the treatments have changed so much. And now, you know, back in the day, some people would defer treatment until the liver got kind of bad. Now we don't even want it to get bad at all because we know that we can treat. And actually these newer treatments, these oral agents, they work better when your liver is not as damaged. So that's also like a really exciting thing that's noted.
Great. Thank you so much for giving us that really detailed overview of what hepatitis is and how it works. So I'm going to forward in our presentation. So the next thing that we're going to talk about, I think it's important to have some background on Medicaid law to better understand some of these issues we're talking about and why certain criteria are so problematic in state Medicaid programs. So just to start, Medicaid is an entitlement program. What that means is that if an individual is eligible, they have the right to enroll in coverage. Medicaid, there's a federal law, and then states have their own statutes and regulations that need to be compliant with the federal law. So when we look at hepatitis C advocacy across the country, the legal advocacy, advocates have filed lawsuits against state health departments on 3 different issues. The 3 are listed below, and I'll talk more about them to try to eliminate certain criteria. The one that advocates have focused on the most is eliminating the requirement for a certain level of liver fibrosis, which Kara was just describing, and we'll talk about more in detail about what we've done in Maryland next. So the first one is that Medicaid programs have to pay for treatment that is medically necessary. That's the main consideration. The way that that's defined is that services are necessary if they're for prevention, diagnosis, or treatment of a physical or mental health condition. State budgetary concerns cannot be the deciding factor on whether or not something is medically necessary. There is some flexibility for states in covering generics when there's a generic available, but care and services have to be provided in the best interest of the patients. So that means that states can only adopt standards that are reasonable and consistent with that objective of the federal law. And some courts have pointed out that even the legislative history of the Medicaid Act, it does speak, the act itself doesn't speak to what medical necessity is, but the legislative history gives us some insight that there's an importance on physicians in determining medical necessity. So we do know that a lot of advocates in their litigation have cited that the American Association for the Study of liver diseases has said that this medication should be provided to all patients with hepatitis C. And that's some really strong support to making sure that people have access to medication. The next thing is that states have to provide services with reasonable promptness. That's a more complex issue. Hepatitis C doesn't progress the exact same among all patients. Correct me if I'm wrong, clinicians. It's not always identical. So for what it takes how long it takes a patient who has no liver fibrosis to get to mild or moderate may be different for another patient. It could take several years, from what I understand, for a patient to reach. So it can take several years for a patient to reach the fibrosis level that their state Medicaid program may require. So if a patient is being recommended for treatment at, when they have no liver fibrosis and their state Medicaid program requires severe liver fibrosis, then it could be several years before that patient can access the cure. And we know that's not reasonable promptness. And we know hepatitis C causes long-term damage. And that the treatment is effective regardless of that, it's going to be effective regardless of whether or not that liver damage is there. So that shouldn't even be a factor. The last thing is that states can't discriminate between beneficiaries in providing care. That one's pretty straightforward. If you have 2 people with hepatitis C, one has, if we're talking more about fibrosis, one has no fibrosis and the other one has severe fibrosis. And the state program, Medicaid program requires that you have to have severe fibrosis to get the medication. The one with severe fibrosis is going to get it, the one without it is not. That's discriminating among people who have the same disease. So next we're going to turn things over to Joanna to talk more about the advocacy we've done in Maryland to address one of the first criteria that we found that was problematic.
So under the Maryland Medicaid rules, Medicaid would require a person to have a certain amount of liver damage or fibrosis, as Kara had described before they would cover their treatment. And they would rate that damage based on this fibrosis score. So F0 is the least amount of damage and F4 would be the highest amount of damage. And given that Medicaid is required by law to provide treatment with reasonable promptness, as Ashley just stated, requiring someone to wait until they have irreversible liver damage to get treated is highly problematic. So how do we get Medicaid Medicaid to change their criteria to allow people with fibrosis score of 0 to get treated. In other words, not making people get sicker. Well, we could tackle it in one of 3 ways or all of these ways. A lawsuit, through legislation, or through administrative advocacy. And as it turned out in Maryland, all 3 actually happened here, and we were ultimately successful through legislation. And just to note that this was not just Maryland's Medicaid program. These were Medicaid programs throughout the country, and advocacy organizations around the country were filing lawsuits or taking other legal action. And in January 2018, the ACLU of Maryland said it would be instituting legal action against Medicaid about the criteria. And subsequently, in the 2018 General Assembly session, Senator Nathan Pulliam introduced a bill to prohibit Medicaid from using this criteria. So just a shout out to some of our partners and other advocacy organizations that Ashley had earlier referenced in holding Medicaid accountable to the law. So the 2018 bill was not successful, but Senator Nathan Pulliam, along with Delegate Janelle Wilkins in 2019, introduced the bill again, SB 598, HB 962, and it passed, thereby requiring Medicaid to eliminate the fibrosis score. So while most states, as I mentioned, had eliminated the fibrosis score, in other ways, Maryland was the first to do this through legislation, and we were really proud of that. Many other states did it either through administrative advocacy, in other words, talking with their Medicaid programs, or through litigation. Next slide, please. So as you can see on this map, the vast majority of states, 47 of them, have no restriction on fibrosis score anymore. The states that do, at least as of August of 2020, include Alabama, Nebraska, Arkansas, South Dakota, and Texas. So while we celebrated the victory of our bill passage, there's always the issue of implementation, and I will turn it back over to Ashley to talk about the continued advocacy we need to do to implement this legislation and remove the fibrosis score criteria altogether.
Thank you. So the advocacy, so the bill passed, it was signed into law by the governor, but continued advocacy was needed. I believe at that time, the effective date, correct me if I'm wrong, Joanna, the effective date for the bill was, I think, October 2019 was when it needed to be implemented. At that time, so after the legislative session ended in April, we weren't seeing progress toward reaching that goal. So the first strategy, which was led by Healthcare for the Homeless, was to publish an op-ed on the importance of treating patients early and making sure that all patients have access to the cure. It also highlighted what had been achieved in Maryland through the legislation and where our state Medicaid program was in implementing that law. So it helped us to put public pressure on Medicaid and to raise public awareness about this issue. And that was in July 2019. So the next thing that was done was Marylanders Against Poverty sent a budget letter to MDH in August 2019, highlighting that this bill had passed and was signed into law, urging that the state, request the appropriate amount of funding to go down to F0 so that that virtually no liver damage that they were required to go down to. And what we saw was through continued administrative advocacy, so reaching out to the Department of Health to ensure that they were actually doing this, we did hear back from them that they would be dropping the fibrosis score requirement beginning January 1st, 2020, which is what happened. It was after the effective date for the bill, so I want to raise that. But we're happy to see that have finally happened. And since then, we haven't seen patients be rejected from receiving this cure because of their fibrosis, though we have seen other issues arise in its place, which we are going to cover, which Catherine is going to cover next. Oh, Catherine, are you still there?
I'm here. Sorry about that.
Okay.
Hi,
That's okay.
everybody. Hi, everybody. This is Catherine. So yeah, I wanted to talk a little bit more about the ongoing issues that the ongoing remaining barriers to treating all Medicaid beneficiaries, which is clearly our ultimate goal. So there are still significant barriers, unfortunately. So the first thing that we see is an ongoing issue with people who have substance use disorder. So as Amanda said earlier, many, probably the majority of people who have substance abuse disorder are Hep C positive. And so there's a lot of Hep C in the population of people who are using drugs, especially injectable drugs. So we definitely want to make sure that those folks are able to get treated. Unfortunately, and in the next slide, I'm going to show you the exact details to this. The Medicaid form that providers need to use to apply to ask for someone to get treatment, otherwise known as a prior authorization form, actually asks about substance use. And the provider's answer to that question often leads to further questions, skepticism often from the managed care organizations or from Medicaid rather, about whether the person is still using, whether they're in recovery, whether they're adherent, and a variety of other questions that no one else who is asking for treatment has to answer. In addition, as a consequence of this, just asking about substance disorder discourages providers, especially those who may not apply for a lot of PAs, who may not be as familiar or comfortable with the PA process. It will discourage them from submitting an application for treatment and discourage their patients from pushing to get treatment because they know that they might be facing some additional questions or some barriers. So of course, the consequence there is that people who are using substances where the levels are highest, the prevalence is highest, go untreated, have delays in treatment, which leads to higher Hep C prevalence in those communities, which leads to higher Hep C incidence with new infections. So all that is just a really terrible cascade. So in a moment, we'll look at the prior authorization form and you can see the details on that. But the other thing I wanted to talk about is specialty pharmacy restrictions. So currently there are 8 managed care organizations in Maryland contracted by Medicaid. And there are several of them that require the use of specialty pharmacies for Hep C medications. And so in essence, a provider who writes a prescription can't just send it to their community pharmacy. It has to be sent with a whole bunch of documentation to a specialty pharmacy, which then through a few different workflows will get in touch with both the provider and with the patient to have the medication sent directly to the patient or to the medical office. It is really difficult. It is a lot of extra paperwork and a lot of extra logistical burden. We see it sometimes as a big issue in the homeless population because often people clearly don't have a stable place. Even if they're ready to be treated, they may not have a good mailing address. So we want the medication to come to Healthcare for the Homeless, and that involves sometimes 1 or 2 or 3 more phone calls just to arrange that. When if we were permitted to use our local community pharmacy with whom we usually partner, it would just be a matter of getting the medication right next door and picking it up. So it really does add a layer of complication that really doesn't benefit our patients or our providers or the workflow in general. So looking at, this is what a glimpse of the prior authorization form. So this is the question about substance use disorder. And it says, does the patient have an active diagnosis of a substance use disorder? Yes or no? And if yes, are they actively engaged in treatment? And if no, then the provider needs to indicate whether they've done an assessment for adherence to assure successful treatment completion. Now, there's several issues with this. An active diagnosis is something that can be subjectively defined. And then are they actively engaged in treatment? Like, what does that mean if somebody has been not using drugs for quite a while and is going to a weekly program? Is that the same as 3 times weekly IOP or buprenorphine every day? And so that's a subjective sort of answer. And then answering yes to either yes to the first or no to the second also brings on other questions in response from the MCOs. And then indicating whether an adherence assessment has been done. Clinical judgment always involves using an adherence assessment to figure out whether someone is ready for a plan of care and whether they are a willing participant. And so it has really been found that the adherence, quote unquote, assessments that we ask people to do formally don't always guarantee, of course, that somebody is going to successfully complete treatment. And so that in itself doesn't necessarily mean that they're going to successfully complete treatment. And also, we need to remember that these questions were written before the vast majority of people could take 1 pill a day for 8 weeks, which is a much different ask than asking somebody to commit to almost a year of treatment, like the previous treatment, which Kara talked at length about. So there's just a lot of issues with this question, and this one question on the prior auth form causes a lot of issues, a lot of delays and rejections of treatment. And as I was saying before, a lot of providers and patients who are hesitant to even get involved in the process. I'll turn it back over to you, Ashley.
Thank you, Catherine. And I'll talk a little bit more about, I can just advance the slides. All right, I'll talk a little bit more about where states are in removing this restriction. But before I do that, I did want to give a shout out to, in Maryland, we have several researchers who've done studies on substance use and patients with substance use and their adherence to the medication, and have found that there really isn't a difference in adherence for someone with substance use and someone without it, and that patients with substance use disorder can be just as successful as those without it. So there really isn't a good reason to deny people on that basis. Unfortunately, where we are in the country right now, it's not reflecting that research and that data. So right now we have 30% of states don't have this restriction, which is great, but the majority of states, and then there's 44% that still require some screening and counseling, but we still have a large percentage of states that require that a person be sober for a certain number of months. And again, it's not really justified when we're talking about the research and guidelines that clinicians are coming up with. So the next thing that we wanted to share with you guys is that when it comes to removing the prior authorization form that Catherine was talking about, there are states that have already done that process or partially removed pieces of the prior authorization requirement. So Indiana, Louisiana, New York, Washington State, Wisconsin, and Michigan have either fully lifted the prior authorization form or have lifted it for specific types of patients. So just wanted to give that research to people too, that it's not impossible to get this prior authorization form removed. It has been done in other states, and it's been done for other medications in Maryland and across the country. So I'm going to turn things over to Joanna to talk more about other barriers that we still are facing to eradicating hepatitis C in Maryland. Oh.
So the first barrier I wanted to discuss is funding and the budget for hepatitis C treatment. Even having passed a law does not necessarily mean that the law gets implemented. And one of the main reasons for that is the budget. It's not right, and it's not even necessarily legal to deny something like treatment based on the budget, but it is the reality of our state, and that's why advocacy has to happen. So as an example, even after Medicaid eliminated the fibrosis score criteria in January of 2020, we weren't even sure there was sufficient funding to cover all of the patients who have Medicaid suffering from hepatitis C for that treatment. And it's not always apparent from looking at the initial budget whether or not there is actually funding for this. We have spent many an hour looking at through different line items to sort of figure it out, and it's generally tucked in funding within other departments of the Maryland Department of Health. And so, for instance, after Medicaid eliminated the fibrosis score in last January, we were wondering whether or not there was actually sufficient money, and the governor had actually dedicated about $29 million plus or so towards access to hepatitis C treatment. But what did that mean? And so it's really sort of analyzing the budget and making sure that there is sufficient funding. And at this point, given that we have had a full year of people not necessarily getting rejected specifically based on their fibrosis score, we've seen that this is possibly sufficient. But with budget advocacy, that doesn't mean our work is done. It's an annual thing. It has to happen every year. Struggle to dedicate funds even after Medicaid was legislatively mandated to remove the fibrosis score. We've heard about all of the other barriers, as Catherine and Ashley have described. And so our work needs to continue to be diligent every single year to ensure that there is sufficient funding for all Medicaid beneficiaries. And considering those barriers, we need to continue, and we're going to continue to increase access to hepatitis C treatment. We're also going to need to continue to monitor the budget every year. And then the other thing I wanted to talk about among the other issues is monitoring treatment for people in prison and leaving prison. About 5 years ago, Maryland instituted presumptive eligibility for people leaving prison so that they would be eligible. This is generally as part of the Medicaid program, so they'd be eligible for Medicaid coverage immediately. We had heard reports that that program was not necessarily being implemented, so we were able to do some advocacy and get budget language to ensure some accountability and transparency for this program. But we have heard that there are continued reports of a potential lack of access for this population, particularly people in prison. And so we are looking into those barriers and how to overcome them and strategizing about the best advocacy tactics moving forward.
Great, thank you. So I am going to turn things over to Kara and Catherine. I think Catherine may have had to step off. I'm very thankful to all of our clinicians and medical folks who were able to participate and collaborate on this presentation, but totally understand that sometimes they're still doing their jobs. They're still treating patients and they have to step on and off during this. So I'll go to the next slide.
So the Maryland Hepatitis Coalition is a group of individuals, it's a volunteer group, and their entire focus is to address issues surrounding hepatitis at large. But we've also seen where we could possibly make the biggest difference right now currently in hepatitis C. So that's been one of our primary advocacy focuses, but we truly do care about hepatitis as it presents in its different forms across the state. We actually are hoping that by listening to this and by being able to see the importance of these issues, we're hoping that people with either lived experience or people who work in this field might be interested in joining our efforts on the Maryland Hepatitis Coalition. And if you fall into that group of someone who either has lived experience or works in this field, but didn't know there were advocacy groups like this, we'd love to have you be involved in what we do. Catherine right now is co-chair. I'm on the steering committee, which is a group of people who help and support the meetings and how they work. But just know that when we're trying to do this work, it does take a lot of people to make change. And we've already worked towards making change in different arenas. And we have a lot of hope that if we either communicate well with different stakeholders so that they understand what issues are and they can help make change, or if we ourselves do things such as, some members testified in Annapolis before, some members have written letters. There was even a summit that was held to bring awareness to different issues. We're hoping that people will see this as something that really should be addressed. And it's really painful to me to think, I've worked in medicine, I've worked in STI clinics, I've done primary care. I can't really think of any other disease where there is a cure for it. And we tell people, no, you've got to wait. Like, you can't get access to this cure. You have to be really sick, even though it works better when you're not. Like, that just does not add up just in medicine. We don't tell someone with diabetes, wait until you're really, really sick and you're in the hospital and then we'll give you insulin. And that's a lifelong med. It used to be with HIV that we would have them wait until their T cells are really low. And then we discovered how damaging that was and made a change. We've discovered it's damaging to wait to cure someone's hepatitis C. And we still haven't made a change. And that's really an ethical issue. So if you want to be a part of the work, you've had lived experience, or you work in this field, we'd love to have you be a part of our group.
Okay, thank you so much. Before we move on to our discussion section, I just want to thank all of our panelists who collaborated on this presentation and helped to pull it together, and were willing to share this advocacy and their knowledge and expertise on hepatitis C with the community. It's really important. It doesn't get enough attention, and I'm happy we could bring that attention today. The next thing that I wanted to say was that for our discussion section, John will be leading that. So I'm going to turn things over to John for that.
Okay, and I will unmute myself. Thank you to all our panelists. This was very informative. This was good. I've read about this, but this was even deeper than I knew before. So thank you very much. I think on behalf of everyone in the audience. Let's see. There's a question in the chat. Is there contact information for the coalition? So if someone could put that in, how do you want people to connect up with you? I think that's one important thing about our Justice for Breakfast series, is that part of the intention is to bring together people who are working in a certain issue or a certain field, but also people who may not be connected into that advocacy arena and need to be able to do that. So there aren't any questions in chat, so I'll kind of throw it open. Put a question in chat, but let me ask if you have any questions for the presenters. Maybe let me also ask, what did you learn today? What is it that stuck with you or that you were surprised to learn? Okay, and we've got an answer in chat. It's steering@googlegroups.com or MHC steering. It's in the chat. So
MHC-steering@googlegroups.com.
okay.
Thank you.
Great. And let me ask, Chara, does the group meet on a regular basis? How do you connect people into your group?
So we meet every 2 months as a group at large, and then there are emails that go out with different updates at different points. And then the steering committee, which is the group that kind of helps guide how the meetings are going to go, and then also supports any work groups. They meet once a month to keep everything on track.
Mm-hmm.
And the meetings are held on the second Tuesday of every month from 11 a.m. to 1 p.m. So every other month, 11 a.m. to 1 p.m.
Mm-hmm. Mm-hmm.
Our next one's going to be in June.
Okay. And are there particular, I think you mentioned people with lived experience, but other people you're specifically hoping will join your coalition?
So it's really nice when there are people who are passionate about doing things, and also especially people who are in the county. We feel like there's an underrepresented group of individuals who need advocacy, who are not, most of our members are in Baltimore City, and they're really good at communicating, hey, we're having this barrier, let's fix it. The county folks, we feel like they have less access sometimes to ID providers and resources. And we really want more of their input into what we're doing, because we want to advocate for them too, but we don't always know how to do that effectively. And so in my opinion, the best way to know how to advocate for a person is to have people who are directly impacted by it communicating, this is what we need. So especially if you're not in Baltimore City proper, we really would love to have those folks, providers, patients, nurses, pharmacists, social workers, policymakers. It runs the gamut, but we just kind of want to work as a group, a unified group.
Mm-hmm. There's a question from Ann Seacott in the chat that's good. You described how the MCOs use specialty pharmacies for Hep C medication, not for all medications. What's the rationale for using specialty pharmacies here? And you described a little of the barriers to that, but why would you do that?
So yeah, it's a little complicated, right? So these medications started out being very expensive, like absurdly so. And so the old treatments of medications, they were even more expensive. They were more frequent. You had to be on them for a longer duration. The whole cost, I think, added up to around $100,000 for a cure. And then the newer treatments happened. I think they were upper 80s, lower 90. Well, I think they were mid to upper 80s for a cure for about 3 months. And that price has gone down substantially. But there was a sense in which I think that, one, there was this old concept that it was hard to treat and you needed to make sure that people were super adherent. And if they missed a dose, that would be it for their cure. The old treatments, it was imperative that they really follow the regimens. The newer treatments, we still want them following their regimens, but the fear that was there about the old treatments, we really aren't seeing worse outcomes with the newer treatments. And then on top of it being expensive, on top of this mythology of, how it's so complicated to make sure someone takes a pill every day, it made it so that I guess they wanted to lock people into specialty pharmacies that do some things with tracking, and sometimes they'll have special monitoring programs that include nurses. Only problem with that is that we have two different care models that are in conflict when it comes sometimes to specialty pharmacies. We have our primary care model, which usually uses a patient-centered medical home model in a federally qualified health center. So we have these like clinics that are designed to take care of patients holistically. So they'll have their own staff calling the patient. They'll have their own staff ordering the labs. They'll have their own staff doing everything for the patient. And then you have the specialty pharmacy offering the same type of services. Only problem is if both of these people are trying to offer the same services and one of them needs to track it and sees the patient every day and the other one needs to track it, but they don't see the patient every day, it can create conflict, especially with our homeless group. So if you have someone who's homeless and the specialty pharmacy is saying, we have to deliver this to your home and we have to do all the tracking, even though they visit their clinic all the time and the clinic has its own pharmacy and the clinic can fill the med and the clinic sometimes is storing the meds, it doesn't make sense to go to a specialty pharmacy. And patients easily make mistakes when they're on the phone with the specialty pharmacy who's saying they have to speak to the patient directly. And they'll accidentally say, oh yeah, I live here, because that's where they're living temporarily. But that's not where they should get their meds, because once, they leave whatever facility that they're currently in, then their meds are going to keep getting delivered there, but they're not going to be there to pick them up. So there's this huge conflict that we're trying to resolve, especially because being locked into a specialty pharmacy, even with some other diseases, have been shown to not be like really beneficial to the patient.
Mhm.
Does that explain?
Yeah, thanks. If anyone else has any follow-up questions, put it in the chat there. Thank you. There's another question, and I think this is probably for Ashley. So what are the legal remedies for someone or the provider who's getting a runaround on getting Medicaid to cover Hep C treatment? Is there a formal complaint mechanism? Are there legal services involved? What do we do with it?
Sure, Sure. So I think this might be a question for me and also for Kara or for Dr. Rosecrans. So as far as the legal remedies, a patient can certainly file a lawsuit. What we've seen around the country is advocates coordinating with patients to bring class action lawsuits, because it's going to be stronger than just one individual case. We're trying to set precedent. And so in Maryland, we have not had to do that. There were advocates. I don't want to name names and commit people to different actions, but there were advocates in Maryland who were considering at one point with the fibrosis score restrictions, bringing a lawsuit on that issue, and looking towards those three pieces of the Medicaid law that I pointed out earlier. The advocates have been utilizing around the country to file those lawsuits. Thankfully, in Maryland, it wasn't needed because we were able to get that legislation through. One of the issues too with trying to bring together a class action on this issue is that when we're talking about something like fibrosis score restrictions, because patients progress differently with liver fibrosis, you may have, if the state law is that you have to have, F4, so severe liver fibrosis in order to qualify for the medication, and the patient, say, is at F3 when the attorney is trying to pull together that class action and trying to get additional people, that patient may get sicker during that time and then suddenly qualify and is no longer part of that class. And I think that's an issue that advocates have had to grapple with across the country in trying to bring these lawsuits in a way that's both effective and gets, prompt relief for the class. But I will say, I think Kara can describe more about sort of the administrative process, the appeals process that providers can go through to,
Yeah. Can I want to bring up two different things. Yes, I want to bring up the issues with this in the appeal, but also just remind me to bring up what's the issue with fibrosis testing and staging. I put it in the chat, but I think it's really important that people hear why that is so ridiculous. So for the appeals process, so it is a little complicated. So we have patients, sorry, my work phone is going off. We have patients who are identified as having hepatitis. And then depending on other factors, there are certain things that need to be on that prior auth form, including that they have chronic hepatitis, which is it's foolish. It's like a remnant of the old way of treating. But truthfully, these meds work when your viral load's the lowest best. So it's actually better to treat people who have something called acute hepatitis, which is hepatitis C, which is where it's very new. It's easier to treat then because they have a lower viral load, the liver is less damaged, the medications work better. But the providers have to document all these things on this prior auth form, including that they have chronic, and this is where it gets a little complicated. Sometimes insurance companies will see, oh, you only have one set of labs, you can't prove that they're chronic, or they won't take their word for it based on history, or maybe they're seeing something flagged regarding substance use, and then they'll deny it initially, and that's extremely common. And that can be disheartening for patients just to see a denial. And it makes it also, we experience this, and probably, I don't know if Amanda's experienced this as well. Our providers, when they knew a patient might get a denial, were actually not writing prescriptions for a time. So it was a deterrent to actually accessing treatment because providers were anticipating the denials, especially if they only scored with their fibrosis level being a 0, and the requirements for a time were F1 to F2 or F2 and above. So because of that, providers weren't even writing the scripts. And then when they did write the scripts, they would get an initial denial. If they were a provider who was less experienced, I know of at least one patient who went to their provider and their provider got the first denial and did nothing about it. And then I stepped in and I was like, hey, by the way, you're supposed to contact the insurance company and follow up with these denials, doing an appeals process where you basically essentially justify why the patient's getting the medication. And sometimes you actually speak to a provider and you verbally communicate why it's so important. That in and of itself can be complicated, because I remember on one of the appeals I did on a peer-to-peer, I was speaking to a pediatrician who had no background in hepatitis. So you can just imagine that conversation where I'm trying to explain to them why it's unjustified to deny the claim, and they're explaining to me what their policy is, and I'm explaining why it's inadequate, and they don't even have a background in the disease. So that is frustrating for the appeals process. Just to explain about fibrosis and why that is kind of a sham even in and of itself. So back in the day, we used to, well, not a sham, I shouldn't put it that way. For it to be on this prior auth form, it is utterly ridiculous. And part of the reason why is back in the day, we used biopsies. Biopsies are very invasive. They're obnoxious to do. But on top of it, you have this large organ and you are taking a tiny little sample from one portion of this organ. You could have perfectly normal cells in that one little portion, and then you could have cancer in another part of your organ. That's insane. So when they did biopsies, and then sometimes people came back as being an F0, and then later on they're dying of cancer. People that was just kind of a shock to some people that could even happen. Then on top of it, we also had other ways of testing fibrosis. We had these lab tests, but the problem is I know of at least 2 patients where the provider accidentally, I don't know how this happened, but the lab accidentally drew 2 samples on the same day, on the same patient for the same test and got 2 different fibrosis levels. What they did was they trashed the one that wasn't as good for them getting approval, and they used the one that would get them approval. But that kind of shows you that there's some variance. And then we have a much better test, a FibroScan, that is kind of using like, it's like an ultrasound that uses, it measures the elasticity of the liver, and that's a little bit better of a way of judging fibrosis. But again, the medications work best when you have less fibrosis. So waiting isn't great. And then if you wait too long, treating the person isn't in their best interest because their liver can only heal so much. So then you're looking at a liver transplant, and that costs people even more money and has more risk. So it really is a dumpster shoot if you wait. And Amanda, you might have some better things to add.
Yeah, no, I totally agree with everything you're saying. I wanted to make one point that I think we haven't explicitly said here yet, which is that it's not only waiting to treat, that it affects the patient that we're talking about, but when you wait to treat somebody, you're increasing the chance that they're going to transmit it to somebody else. And we're really never going to be able to get ahead of Hep C and get on the road to eliminating it until we can immediately treat people as soon as it's identified and prevent transmission. I did want to address Max's question a little bit more about avenues for when you get a denial from the insurance company. So obviously you'll need to go through the formal appeal process if you get a denial. But starting even a couple of years ago, I think Kara and the Hepatitis Coalition started a tracking spreadsheet where it doesn't have any specific patient information in it, but we had shared that with a number of providers to track these different denials that we're getting so we could look for trends. We met with Maryland Medicaid. Our first meeting with them was in December of last year, and really kind of addressed or brought to their attention these different categories of denials that we were seeing. And they did, they were open to, if you go through the formal appeal process and you're not satisfied with the results, or you think people are getting denied when they shouldn't be, we should take that directly to Medicaid, either the pharmacy director or the CMO of Medicaid, and have them look into that. So if that's happening, I would say, I don't know, Kara, if you want to, if we want people to continue to use that spreadsheet, but I found that it was very helpful for us sort of as a group to track trends.
So we definitely want more names in that spreadsheet because we have continued conversations with Medicaid, and it would be nice if, if we're staying on top of any positive or negative changes that are happening as a result of these conversations. If you are interested in having information on the spreadsheet, the email that I gave before for MHC hyphen, I don't know it off the top of my head, but it's the email that's in the chat. If you want to reach out and say you have some examples of patients who have gotten denials, we ask you about the denial, we ask you about the appeal. We're not going to ask you like the patient's name or anything like that, but we do ask for insurance information, and we want to understand which MCOs are denying and why they're denying and what happened upon appeal. Because when we have this picture, when we talk to Medicaid and we explain why it is we're struggling with success in this area, and we can cite these things as being barriers, they do, we've discovered they do listen. And it's more powerful to have actual tangible examples that they can see than it is to just say, hey, people are telling us they're seeing this in the field. And then they're like, okay, give us an example. So it does help us.
Yeah. And I'll just add to that, because I think that we should highlight that There have been, so there are local health departments that are actually part of the Maryland Hepatitis Coalition and have been instrumental in helping move forward the advocacy. But in addition to that, advocates, as Karen and Amanda were saying, have been meeting with Medicaid more recently to talk about these issues. So every issue that we've raised today has been raised with Medicaid and is under consideration, thankfully, towards seeing whether or not we can change some of these criteria, or at least the way that the prior authorization form frames certain questions. So in particular, one of our biggest interests is the substance use questions, because we don't see the utility in those. But I do want to say that, Medicaid being aware of these issues, we do think that there is, I don't think people go to work for state agencies if they don't care about the issues that they're working on, right? And I think that in Medicaid, we have identified quite a few people who do care about treating patients who have hepatitis C and want to do the right thing and want to figure out how to reframe things like the prior authorization so that it's not preventing providers from treating, because that's not the goal, is for providers to say, oh, well, these questions, my patients, not going to be able to answer these in the way that would get them coverage, so we're just not going to ask. They don't want that to happen. So we do see them as a partner in trying to address these issues, and hopefully in the future in eradicating hepatitis C in Maryland.
Mm-hmm. Well, let me ask, if this seems terribly obvious what we should be doing with Hep C and Medicaid, is it the cost that is the underlying problem here that is causing resistance to treatment?
I think it's a couple different issues. So I think the cost has been the major factor. The medication, when it first came out, like Kara was saying, was around $80,000 or more. Mm-hmm. And so state Medicaid programs then sought to find ways to limit who could access it to try to do cost control, which is not something they should be doing under Medicaid law, right? So that was one factor. I think the other thing that we've seen, though, through our conversations with Medicaid and the research we've done, which I would love for Kara and Amanda to describe in better detail, is this difference between, I might be phrasing this wrong, clinical guidelines and then practice. So if you guys could talk more about that piece.
Yeah, so just to explain though, because of the evolution hepatitis C took, what Ashley said is absolutely correct. People had this idea that it was like super expensive. If you look at the combination of the old treatments combined with not treating someone and them advancing to liver cancer, and like I said, those fibrosis tests, they don't always show how advanced you are. That combination is astronomical and it costs us a lot of money. It costs us way more than just treating everyone, which is why some states went to different models, including subscription models, where it's like everybody gets treatment and then they negotiate with the drug companies like an overall price, essentially, to just get that done. And it's been very successful, and some advocates have advocated for that here. The other thing, the clinical guidelines and FDA approval. So that's been a lot of the debate that we've been having. So when the FDA tests a medication, it's not approved for anything outside of what it's tested for. And then there are certain things where they'll say it's an unlabeled use, according to Medicaid, which is different than off-label. So you are never allowed to use a medication for off-label use, but you are allowed to use a medication for unlabeled use, which is an indication that's usually based on clinical guidelines. Things like when we work with medications more and more in the clinical practice, when there are other studies that are done through research, we find that certain medications have efficacies that we weren't aware during the FDA studies. And to apply for more FDA approval is a huge process. And I think people are becoming more aware of that with the COVID-19 vaccines. It is a process to get FDA approval, and there are certain pipelines you have to go down. And just because a medication is FDA approved for one particular thing, it doesn't mean it can't have other benefits. It just means that one thing was tested and approved by the FDA. when it comes to clinical practice, we'll have guidelines from different organizations. I saw in the chat like AASLD and IDSA were mentioned. Those are two groups that, based on clinical practice, based on what we're seeing in the research, have made different guidelines. Like the chronicity thing I was talking about, where if you don't have chronic hepatitis C, like they're saying, oh, you can't be treated. When really what AASLD and IDSA found was that it's actually really beneficial to treat people with any level of infection, because it really works, and it reduces the amount of disease burden. Exactly what Amanda said, you're not transmitting it to someone unknowingly because you're getting treated really quickly. So there are things that in practice we've learned. Now with the conversations, they keep saying, well, that's not on the FDA label. They only did it for these groups. And part of the reason why they did it with certain groups was to prove how efficacious, how well it worked for people who are the hardest people to treat. So they did a lot of studies around people who had cirrhosis. And the reason why is because they're the hardest people to treat. And if you can show a drug works really well in those people, then you've got something. Whereas acute hepatitis, that is some of the easiest to treat. And also, because the medications back in the day were so damaging, we wanted to wait and see if people cleared so they didn't have to feel like they had the flu for a year. So there are practical reasons why they never did those trials for those patients. And then that's the reason why further research and further clinical knowledge usually informs how we apply medication. But Medicaid has kind of fallen behind in that area because they're not taking that into account with their guidelines for approval. And that's what makes this so much more complicated. Amanda, you can fill in any gaps.
No, I think you said it all just right. I don't have anything to add.
Okay, thank you. There's another question from Max Romano, who had to leave, but he said he's curious if there is a complaint mechanism to state Medicaid, even if you eventually get an approval on appeal. And he notes that, you know, like many clinicians, you fight to get your patient's treatment plan approved, including the medications. And yet you had to fight so hard to get that done. I take it that it's the advocacy that the coalition is doing that is trying to point out to Medicaid that even if you succeeded on an individual basis, you shouldn't have had to jump through those hoops for the precise reasons that Kara just mentioned. That's my guess as to the answer, but do any of the other advocates and clinicians have anything to add to that? Like how to persuade them that you shouldn't have to jump through all these hoops, even if you succeed for individual patients?
I'm not aware of any mechanism that a layperson can do to complain about these things after they've had the success of being cured, other than maybe speaking at events that have laws related to this, or at the general like Medicaid meetings. But those to me don't seem like formal complaints in the way that that question is being geared. So I'm personally not aware of that. And I think that's part of the reason why we're trying to fix this, because we think that the point of Max's question is completely accurate. I think that Medicaid makes a very reasonable statement, actually, that it is kind of complicated to allow just anyone to get access to treatment if anybody writes a script for something, when the medications are in general more expensive than the average duck. You know what I mean? Like they're more expensive than some other medications. So they're trying to make sure it is appropriate to get the medications. The only problem is, so they've created so many barriers that now it's an unreasonable level of security that's actually becoming a deterrent to accessing treatment. You know, we were talking recently about providers who can only prescribe if they're ID providers or GI or a specialist in that area. And then if you take Share the Cure, you can do it as a primary care provider. And we recently encountered a provider took a different training class that was not Share the Cure, but it was equivalent essentially. And they got denied because they were not considered to be an appropriate provider to prescribe. And to me, any kind of training that does the same kind of overview and covers the same threshold of knowledge, that seems to be appropriate because these medications aren't complicated to treat. I do get how sometimes I have seen some providers who are so far removed from hepatitis that they'll see that somebody has a positive antibody, which means that at some point you were exposed to a virus. But they don't look to see if the person actually has the virus. We talked about those people who are naturally cleared, and they didn't look for that. The person didn't have a detectable virus, thus they're not going to need treatment because their body got rid of it. Their body, like, there's so many things we overcome. We overcome the common colds. We overcome like so many diseases that we get rid of, you know? And sometimes our bodies can just kick it out. That's what our bodies do. And there are some providers who just didn't understand that with hepatitis. And so they did refer to GI when they saw just an antibody. And I could understand not wanting providers like that to have no barriers to being able to write that prescription and start that patient on those meds. But I don't think that would even happen, because I think having a baseline of just a viral load, that would seem reasonable to me, to have to submit a viral load, a current viral load, and you know, then get them started on treatment. But I do understand where they're coming from. They're trying to make sure it's not completely irresponsible.
Yeah, I think just to Max's point again, you know, I think on our spreadsheet, we're also tracking, you know, if you were initially denied or had some kind of pushback, even if you got approval for the medication, we still want to put that in this spreadsheet and keep track of that and take it back to Medicaid to let them know that this is happening. Because even if the medication is approved, it is still a barrier to have to jump through hoops with the MCOs. I also am not personally aware of any like formal complaint mechanism through Medicaid, although probably we could find, I'm sure if we look through their website, there's probably some way to file complaints. But I don't know the productivity of that. We're talking when we have a nice consolidated list and group from this group and people who contribute, that's probably going to be powerful.
Yeah, I would agree with that. I think, you know, there's typically with state programs and also with state providers, there's typically a process to be able to, you know, if it's a provider, you can complain to the state program. If it's the state program that's causing the problem, you can complain to the federal government. So I assume that there's probably, I have not heard of advocates using it, but for other issues that are happening in with state programs, advocates may go to the federal counterpart. So I think here it would be U.S. Department of Health and Human Services, which I believe issues guidelines on around hepatitis C treatment as well. I might be wrong on that. I need to double check. But the problem with that process that we see sometimes is the delays in getting a response. I know that, you know, on other issues PJC has worked on in the past, going through a federal administrative process for complaints can, you know, lead to those delays, or it may depend on who the current administration is on whether or not they're going to prioritize that issue. So I think that the route that we're taking as far as, you know, local administrative advocacy with Medicaid is the most effective route that we have right now, because we have opened those lines of communication with Medicaid, and they have been willing to engage with us and talking about this and receiving the research from the clinicians to help inform, you know, whether or not they're going to make these changes. And again, we hope that they're going to make the changes in the near future, but we'll have to see what happens and if we have to continue looking at other tools that we can use for this advocacy.
Mm-hmm. In the chat, Anne asked, 29 million was allocated in 2020. Do we know what the 2021 allocation is for treatment?
I think Joanna and I can answer that. I think the answer is we don't. I don't think that we know yet. I know we were looking for that information during the 2021 legislative session, trying to figure out how much had been allocated. But it was, like Joanna said earlier, it can be buried within those different line items. And may not have been, you know, specifically laid out as hepatitis C treatment access. I know in the past we have seen that, I think, where it was easier to identify exactly how much was laid out, but haven't been able to find that information this year. I think the other thing that we're waiting on, including the budget, is current data on how many people have hepatitis C in Maryland Medicaid program, how many people have received, how many people have been treated, and who still is left to be treated. In past years, Medicaid has provided a report to the legislature on with those statistics. In the past, the statistics have been outdated. So I think the most recent data we've been able to find was from FY 2016. Which is several years behind. We were aware that Medicaid, I believe, was going to publish more recent data this year, but we have not seen that report yet. But Joanna, did you have anything else to add on the budget or on the need for data?
Well, just to say, yeah, I agree with everything you said. And yeah, we unfortunately do not know yet. We're still waiting for the final budget to come out. But just to stress that that's part of the reason why for whatever providers or people with lived experience that are able to share with us in the coalition where you are seeing denials, because aside from the budget, if we don't have at least that information, but they're still denying people based either on legal grounds or not legal grounds, we do want to know about it so that we can nip it in the bud. And certainly, if there isn't enough money allocated in the budget, that's going to be a pretty clear indication of sort of the reasons why they are denying. But we want to make sure to know sort of what those complaints and denials are. And then assuming that the budget comes out and there is sufficient allocation, then we can then go ahead and bring those examples to Medicaid. So yeah, we're still waiting.
Anybody have other questions for our panelists or ideas or anything?
Just to answer Anne's question, we did bring up following the AASLD and IDSA HCV treatment guidelines. We are still in discussions about those, but we also presented a paper explaining the benefits. So.
If there are no other questions, one thing that I would just add is that I think our hope from this discussion today is that for every community member, policymaker, advocate, grant funder, this information that you've received today, we would love for you to be able to share it with others that because this is a disease that does not get a lot of attention. And also, when you see issues arising with other diseases that kind of mirror how the treatment criteria for this one has been treated, we hope that you'll advocate to make those changes, that you'll support hepatitis C medication expansion, whether that's through the legislature or through other avenues, and yeah, that you'll share this information and help us in this fight.
Okay, well, thank you everybody for attending today. And I hope you'll all stay in touch, particularly with the coalition as they keep on fighting to get this covered by Medicaid. Have a good day, everybody. Thank you. Thank you to the presenters.